Hello, everyone, and welcome back to Dementia Basics. This is our second video, and I'm pretty sure you had a few questions from last session by Dr. Andrew Frank. I'm pretty sure you also had been thinking about those changes in the brain and how those changes could potentially lead to dementia. During this session, you will understand in depth the definition of dementia, but also other conditions such as mild cognitive impairment. And definitely you will get a better understanding of different types of dementia. Dementia as an umbrella term, but also those type of dementia, such as Alzheimer's disease, dementia with Lewy body, frontotemporal dementia, or vascular dementia. I highly recommend you to watch this video on demand and listen to Dr. Frank Knuffel. He's a physician from the Rare Memory Program. And get ready with those questions for the Q&A, the live session, on June 24th at 6 p.m. So I hope to see you all there.
Good afternoon, everyone, and welcome to this, the second session in this series of 3. My slide doesn't want to advance. Yes, it does. Here we go. And so this is the what you heard about last time, which was sort of the aging brain, anatomy and function, cognition, memory, and some prevention. So today this is the plan. We'll be talking about dementia specifically, looking at it as a chronic disease, some classification elements, talking about learning and forgetting as concepts, and then talk about different types of dementia, and finally do a little bit of contrast between dementia, delirium, and depression. And then next week or next time, there's going to be the session on research and services. So I thought before we continue, I would just very quickly review some of the highlights from the last time, the parts that are important, because actually we're going to refer back to these today. So again, this is the image of the brain and sort of the right side of the brain. The person is looking to the right, and you have the frontal lobe, parietal lobe, occipital lobe, etc. And hearing, vision, executive functioning, language, they each have their place. Visual-spatial ability as well. They each have their place in the brain. And so you can imagine if parts of the brain are damaged, that they will affect different function. And then this is orientation here in the temporal lobe. And then if we turn the right side of the brain around and look at it from the left side of the head, we get this picture, and then we get this important piece here, which is the hippocampus, and then we have the sense of smell as well. So just to recap, we do have somewhere between 20 and 100 billion of these guys in our brain. They're neurons, and they have a cell body, they have a long axon, and the dendrites receive information. And the important part here is that the communication between the neurons goes from axon terminal to the dendrite receptor of the next neuron. And these neurotransmitters here are the communication, the link between electricity on one side and then electricity on the other side. And that's important when we talk about treatment later on. And this was the three-dimensional view of the neurons. And you see this one here is yellow, so it's sort of active, it's lit up. And the axon then lights up this one. And then depending on the rest of the information this neuron receives, they may or may not light up, and then the information goes down and so on. Very important to the brain is that it is in a closed box, which is good because the skull protects the brain, but it is bad because that means that all the food and all the energy and the oxygen has to come in through these pipes. And so it's one set of pipes going to the brain, and then they branch off into smaller and smaller vessels. And again, we'll come back to why this is important later on. We talked about some of the things the brain does. remembering, orientation to time and place, concentration ability, sorting out the things we need to focus on because we're bombarded with way too much information to manage, language and communication, visual spatial ability, and executive functioning. And we said that with normal aging, we do lose a lot of neurons over time, about 50,000 per day. So then let's talk about today's session. So what is a chronic disease? A chronic disease has a couple of elements. It takes decades to develop. And the best thing that medicine can do at this time in chronic diseases is to try to decrease the symptoms, to treat the symptoms. So if we take osteoarthritis as an example, here we see, a joint, and you see that this joint is now been affected by arthritis, so that the padding is gone, and this distorts the shape of the joint. There's swelling, and this happens over decades. So you might be in your 40s and you might start feeling your joints are a little stiff sometimes in the morning, and then in your 50s it gets a little worse, and in your 60s it gets even worse, and in your 70s you start showing deformed joints, and in your 80s then your hand might look something like this. So it takes decades to develop this kind of a condition, and treating symptoms is the best we can do. There is no treatment for arthritis, but what we can do is try to decrease the inflammation associated with it. So the pain, the inflammation, we can try to decrease and slow the process somewhat, but there's no cure for arthritis. And so the same thing happens with chronic obstructive pulmonary disease. So a chronic lung disease, as the lung tissue just gets broken, destroyed over time, there's no way of turning that back. But we can treat an infection that results from the lung disease. We can give you inhalers that'll help you breathe despite the condition of the lung, but there's no cure. And so we go on with chronic renal failure, so kidneys, chronic heart failure, the heart, and dementia. So these are all the chronic diseases, and dementia is classified as one of those. So to go back, it does take decades to develop, and that is the new thinking now. And we can treat the symptoms, as you'll see later on. So classifying cognitive decline. Before we go into that, we'll talk about activities of daily living. So this may be a new concept for some of you, but so I'm just going to take a little bit of time to talk about this. So basic activities of daily living are things we have to do every day. Every day we have to dress ourselves. That's what society wants. We have to wash ourselves, we bathe ourselves, we toilet ourselves, and we have to eat, and we have to feed ourselves. So those are the basic activities of daily living. Then there is instrumental activities of daily living, and these are what you could call higher activities of daily living, and they don't necessarily need to be done every day, but you do have to be able to manage them to be able to function on your own in a society like ours. So you do have to manage your finances. You have to do some shopping. You have to manage medication. You have to make meals, and so on. And you can see that these are all more complex activities, and they usually have to do with how we interact with our society, with our environment, whereas the other ones, sort of the self-care, that's only about us. Like, I have to be clean, and so that's only about me. These are how we interact with each other. So this is probably the most important slide you will see today. And it tries to depict sort of the three general categories we use right now to talk about how the brain can change as we age. So on the left, you have normal aging. In the middle, you have mild cognitive impairment. And on the right, you have dementia. And so some people talk about dementia as though it was a disease, but it's not really. There are diseases that cause dementia, but dementia is like more a condition, And so we'll talk about that a little bit more later. But your brain can age normally. It can have mild cognitive impairment, or it can have dementia. So let's try to define those a little bit. With aging, and you heard this last time, there are mild changes in memory, language, and executive functioning, and visual spatial abilities, etc. So these changes are mild. And overall, as we age, we can still do our instrumental activities of, say, daily living, right? So I might forget a little bit, but I have a system to make sure that I pay my bills every month, and I write things down a little bit more, but perfectly fine. I can function in society completely independently. Now, mild cognitive impairment, now we have a significant change in memory, language, or executive functioning, or other domain, but I'm just highlighting these three. And so it's a measurable change. So if you take 100 people, you do a memory test with them, everyone is going to be in that range somewhere. But if you fall well outside the range in memory, it means that your memory is impaired. It's below normal, right? So to have mild cognitive impairment, you do have impairment in one or the other of these domains. You may have impairment in one or two. And again, these do not impact your capacity to live alone. So now your memory is even worse than just aging normally. So now you really do need to write things down a lot more. But you develop systems and you can still function despite the fact that, you know, you're not functioning as well in language or executive functioning or the like. So next we go to dementia, and you can see where this is going. Now we have significant changes in memory and language and or executive functioning, so multiple domains again. But this time we do have impaired instrumental activities of daily living initially, and then we have impaired basic activities of daily living subsequently. So aging, small changes, but we remain totally independent. Mild cognitive impairment, significant changes, but we remain generally independent. And then we get to the stage of dementia where we have significant difficulties that impact our ability to live by ourselves. Oops, the arrows are missing. Okay, normally the slide has arrows, something happened to them, but the way you normally move on this graph is from aging towards mild cognitive impairment. So if you have a condition beyond normal aging, you might over time start drifting into this area. So now your memory used to be pretty average, but now your memory is below average. So that would be moving from aging to mild cognitive impairment. Now, there are conditions that can cause mild cognitive impairment that are treatable. So let's say you have a severe thyroid problem and it's affecting your ability to think clearly. And so we test you and you do very badly in testing, but you're still functioning okay in society. So we'd call you mild cognitively impaired. If then we treat your thyroid problem, you may well end up coming back to normal aging. So the directionality can be this way and it can be this way. So it can be reversible. Mild cognitive impairment can be reversible. However, if you move from mild cognitive impairment to dementia, that is not reversible. So that's a one-way street. So this, as I said, is sort of the most important picture of today. And if you can understand how, and these are overlapping circles, right? So there is no, I can't say that on, January 15th, someone transitioned from mild cognitive impairment to dementia because there's this gray zone, right? So it's gradual, it's over time, but eventually you do end up in one end of the circle or the other. So let's just do a couple of definitions. So the World Health Organization says dementia is a syndrome. So it's not one disease, it's a syndrome. It's chronic, progressive, and it's caused by a variety of brain illnesses that affect memory, thinking, behavior, and the ability to perform everyday activities. And again, you see that the dementia requires that impairment in everyday activities. Another set of definitions is neurodegenerative disease. So we want to just be clear, what does that mean? So neuro refers to the nerve cells. Degeneration is the progressive deterioration of the structure or function of tissues and organs over time. So neurodegeneration is that progressive breaking down of the cells, their connections, the circuits in the brain, and impacting function eventually. It's progressive, as we said. And one of the important things later when we compare to delirium is that it does not affect our level of consciousness. So we're quite conscious, but we're just not able to sort things out. And again, here's another image. Dementia is an umbrella term. It's not a specific disease. And so all the things that can cause dementia include these things, which we will talk about, of course, in more detail later. So we're trying really to be explicit that dementia is the severity of the condition, and Alzheimer's or vascular disease are the causes that you move from normal aging to mild cognitive impairment to eventually dementia if things keep getting worse. All right, this is one of the boring slides. We just want to give some of the statistics so that you have them. But you all know that dementia affects a large group of people. 564,000 Canadians currently live with dementia. There's actually 16,000 of these that are under the age of 65. About 25,000 new cases are diagnosed every year. And the number of people that will be living with dementia is almost 1 million in 15 years. And 1 million of Canadians are already directly or indirectly affected by the disease. So that includes the caregivers. And 10.4 billion is the cost to Canadians to care for people with dementia. So you're obviously here because you understand the seriousness of it, but just to give you those numbers. All right, so we did say that dementia can be caused by a number of things, and the first thing is to regroup them into two groups. So there are the diseases that happen inside the neuron. So bad things can happen inside the neuron that can cause the cells to get sick and to die, and the connections between cells to deteriorate, and ultimately brain function to deteriorate, and then our ability to live independently to be affected. So these conditions, Alzheimer's, frontotemporal, Parkinson's, Lewy body, posterior cortical atrophy, Huntington's, etc., these are inside the cell conditions. Okay, so they happen from the inside by themselves, as far as we know. They might be genetically determined or whatever. Then there's the group that are outside the cell. So here the brain cells are affected secondary to another problem. So vascular dementia, if you cut off the circulation to the brain, of course you're going to hurt the brain. Normal pressure hydrocephalus, if you build up the pressure in the brain and you squish the neurons, of course they're not going to function as well. And encephalopathy that's traumatic, right? That could be from boxing, right? If you beat up the brain, if you keep hitting it again and again and again, you can damage the brain from the outside. Toxins, any kind of chemicals that get into the body can affect the brain and hurt it. And alcohol, chronic use of alcohol, which is the Korsakoff syndrome, would be one of those examples. Traumatic brain injury, we know unfortunately that even young people that are involved in car crashes or motorcycle crashes can have severe brain damage that can affect them for life. And then there's infections, such as like HIV and others. So again, inside the cells, bad things can happen, but also outside the cell, bad things can happen. And any of those things could lead to moving from normal aging to mild cognitive impairment, and if it's not under control, from mild cognitive impairment to dementia. All right, so we're just gonna look at the causes of dementia in two groups, sort of the under 65 group and then the over 65 group. And you can see by the color distribution that they're quite different. So in the under 65 group, you see that frontotemporal dementia has, 15%-ish. Alcohol is 10%. Lewy body is in there. Huntington's is in there. Alzheimer's is only about a third of cases, and vascular is actually relatively low at under 20%. Compare that to the over 65 group. Now you've got Alzheimer's again, about a third, but there's this mixed dementia group that's another third, which includes Alzheimer's, but also vascular and frontotemporal. So the mixed dementias are now a third. Alzheimer's is a third. So you can see this, 2/3 of this is now sort of that, that group with the Alzheimer's, the vascular, and then the vascular alone is almost another third. So you can see that the majority are vascular, Alzheimer's, and mixed, with pure frontotemporal being a little bit more rare, and same with Lewy body, it's a little bit more rare in the older group. So when we think about the causes that are inside the cell or extracellular, but if we look at, what is the role that genetics actually plays in this? So this table tries to show the different subgroups of dementia causes, right, the different diseases, and then what percentage is familial, meaning that it's genetically transmitted, versus what's sporadic. So it just seems to come on its own, or we don't know why. So Alzheimer's disease, only up to 5% are actually familial, with 95% being sort of more spontaneous. Now, vascular dementia, it's familial if there's risk factors that are transmitted in a familial way. So, for instance, if a lot of people in your family die from heart attacks, and not necessarily related to smoking, but just because the family has high cholesterol or high blood pressure, then of course you're more at risk of having vascular dementia as well, because it's the same plumbing, right? So the vascular risk would be familial, but most of vascular dementia is still related to lifestyle. So heavy smoking will damage your circulation, which will damage your brain. Frontotemporal dementia, now here you can see that there's a lot more genetic role in frontotemporal dementia. So as much as 40% of cases of FTD will be genetically linked. In Lewy body, it's rare. Parkinson's disease, it's rare, 10 to 15%. And Huntington's disease, of course, is the unusual one where it is directly genetically transmitted from parent to child, 100%. All right, so we've talked about dementia as a chronic disease. We've done some classifications. You've got the 3 interconnecting circles. So now let's get a little bit more down into sort of life evolution. And this set of slides is what I want you to understand, how the brain develops over time, and then the impact of dementia subsequently. So in normal learning, and I use the image of the onion. So you see here the onion, it's layers, right? So like we're born and we really don't know a heck of a lot. We learn the language of our parents and we learn to count, and then we go to school and we add another layer, then we can do multiplication and division, and then we go to college and we learn accounting, and that's another layer of math, right? And similarly in language, first we learn to name individual items, then we can make short sentences, then we can make paragraphs, we can write a poem eventually, and a book. And of course that would be sort of increasing layers of the onion. So let's just talk about child evolution. So first we learn to hold up our head, pay attention, and we can say single words. Then we learn to walk up the stairs. We follow one-step directions. We can use a spoon, right? We understand more and more. We develop a growing vocabulary. We start brushing our teeth. We dress. We become continent. Our fine motor skills get better and better. We can tie a bow tie. We can make 5 to 6 word sentences. We can name our friends now. It's not just boy and girl, right? They have names. We can improve concentration. Now we can read an entire book. And as I said, the mathematics side, right? We go from simple math to balancing a checkbook to managing a $60,000 budget. Now, unfortunately, in dementia, it's the reverse. So what we're doing, it's like the onion is starting to rot, if you like, and so the first layer that goes is the outer layer. So the very first thing we'll lose is how to manage our $60,000 budget. Then over time, we even have difficulty balancing the checkbook. And as that progresses, then eventually we have difficulty doing any kind of math. Then we don't have the concentration or the ability to follow the storyline, and reading a book becomes too difficult. And our concentration isn't as good anymore. And with time, as the dementia progresses, we forget the names of our friends and our language deteriorates. We get shorter sentences. And you can see how really dementia becomes the unlearning of everything that we learned in life. So it's a chronic disease. There's different ways of classifying it, but you progress from left to right, starting in normal aging, going to mild cognitive impairment, and ending in dementia. And it really is, we learn things when we're young and as we get older, and then after sort of 55-ish years old, we start unlearning. And the rate of unlearning, though, is very much dependent on if it's normal aging, if we're transitioning to mild cognitive impairment, or if we did transition to dementia. So now we're going to get into the actual causes of dementia. So here are 2 images, and you see the normal brain. I call it the grape look because it's nice and plump. And this is more the raisin look, right? You can see how there's been shrinkage in all of the areas of the brain where the neurons are. And so obviously there's been a lot of neuron death. And you can see how it's really global. So this is obviously very late stage Alzheimer's disease. This, I wouldn't see this in the clinic here, for instance. But we do transition from this to this with Alzheimer's disease. So going back to the cellular level now, what are those plaques and tangles that people talk about when they talk about Alzheimer's disease? So on the left here, you have sort of another cartoon view of neurons, right? You have your neuron, the cell body, you've got the dendrites up here, the short ones, and then you've got the long axon coming off on the end. And this would be a healthy brain. Now, when it comes to Alzheimer's disease, we have 2 things going on. Inside the cells, we have this breaking down of the pipes that support the actual structure of the neuron, and that's the tau protein and the neurofibrillary tangles. And then on the outside, you have these collections of amyloid protein that are the plaques. So both of these have to be going on to have a diagnosis of Alzheimer's pathology. And again, in 3 dimensions, you can see here you have your normal cell. They're all sort of crisp outline. They have nice shape. There's nothing going on between the cells. And then here you have the cells that are shriveling. Their structure is breaking. Even this one here, its structure is starting to break down. It's not smooth edged. The microtubules are not functioning properly. And you've got these plaques, these big amyloid plaques which accumulate in the brain. And that is the pathology. That's how we diagnose Alzheimer's disease. So this picture tries to show how the disease progresses over time in the brain. So if you recall, this is the temporal lobe, and we're only looking at it from the outside, but if we were looking at it from the inside, we'd know that that's where the hippocampus is. And you see that the biggest blue, and blue is the stain that's showing up the damaged part of the brain. So the first areas impacted are the temporal lobe, the inside, the hippocampus. So we do start having difficulty with memory. And you see there's a little bit of change right here beside, but this is the frontal lobe. So we have a little bit of difficulty with planning, executive functioning. So the highest level of functioning, we used to be able to organize dinner for 25 people at Thanksgiving. Now, consistently getting dinner ready for two is enough of a workload. And then you see in the next picture here, it's getting darker. So now it's not just the hippocampus on the inside, it's moved out to other parts of the temporal lobe, and now language is going to be affected, sense of direction, sense of time, and executive functioning, of course, is getting more impaired over time. And then finally, in the late stages, you can see how the disease is now spread throughout the brain. And in addition to having memory problems and executive functioning problems and language problems, and now even basic care, remembering to take a shower, remembering how to feed oneself, right? These will be affected towards the advanced stages of the disease. And again, so there are people who would be considered completely normal, who may show some changes in the brain that would be called Alzheimer's type changes. So you can be functionally normal, test normally, live independently, and yet have early changes in the brain. But as they accumulate, you go from mild cognitive impairment to mild Alzheimer's dementia, to moderate Alzheimer's dementia, to severe Alzheimer's dementia. And you can see initially it's the memory loss, and daily activities are preserved. You get more confused. Financial tasks become difficult. Remember, those are sort of the more complicated things we do. A little bit of judgment difficulty, maybe a little bit of mood change. And then increasingly, the memory gets worse. We start repeating. We might have other symptoms of brain disorder, like hallucinations or delusions. We may worry that bad things are going to happen to us. Language and thinking is affected. And again, eventually we don't recognize even our loved ones. We can't communicate effectively, and we are dependent in care. So as the disease progresses, we move towards the right. Now, all of these things can make the disease worse. So genetics, having a family history, although it's only 5% that's sort of directly genetically affected, there is an increased risk of having Alzheimer's disease if you have a direct family member that has Alzheimer's disease. Education, we don't really understand why, but having more formal education and even having more informal education seems to protect against Alzheimer's disease. And cardiovascular disease, so hypertension, cholesterol, diabetes. This affects, as you probably learned last time, and we'll talk a little bit more again today, the plumbing, right? The circulation to the brain. So if you damage the circulation to the brain and you already have a little bit of Alzheimer's happening, it may amplify that. It may make that worse. And respiratory disease. So if you have sleep apnea, for instance, where during the night you'll spend extended period of time where you're not breathing, even though the circulation might be great, if you're not breathing in, you're not getting oxygen in, and then there's no oxygen going to the brain. So the brain will still suffer. So if you have a little bit of Alzheimer's disease and breathing difficulty, that'll make things worse. So this you've talked about last time, but again, I just want to remind everyone that, eating well, sleeping well, having some kind of healthcare provider that helps you stay as fit as you can will help your brain. If your kidneys aren't functioning well, your brain will be hurt. If your liver isn't functioning well, your brain will be hurt. Physical exercise is the best thing you can do for your brain, because when you physically exercise, your muscles in your legs are calling for more oxygen, you're breathing more deeply, your heart is pumping harder, and guess what? The brain benefits from all that extra blood flow, and that's a good thing. Cognitive exercises are good for the brain, especially ones that are affecting different parts of the brain, and of course, social engagement. Now, when we talk about Alzheimer's disease, we do have treatment, and some of your loved ones may be on some of these medications. So just going back to the neurotransmitters, so this is the connection between two neurons, right? This is the axon from one that's been lit up, and this is the receiver, the dendrite of the next. When these neurotransmitters cross the gap and attach, they change the chemistry here, and they cause a new electricity to move on. So the very first group of medications that was discovered for the treatment of dementia of Alzheimer's type then was these cholinesterase inhibitors. So what we want to do is we want to increase the amount of acetylcholine, which is one of the neurotransmitters, but in this case, the one that seems to be most associated with memory. If we can increase the amount of acetylcholine available to the brain, even though this axon may be starting to get weak and die, if we can have more of this, maybe we can keep more of the function. So there are 3 of these medications: donepezil, rivastigmine, and galantamine. And you can see here that they were discovered in different times and by different companies. What's interesting is that galantamine actually comes from the bulb of the daffodil. And I'm actually not very good at reading Egyptian hieroglyphics, but apparently they refer to the brain power of the daffodil in some of the scripts that we've discovered in the pyramids and in other Egyptian areas. So just a funny anecdote, but these are the medications that we prescribe. And again, this is not a cure for the disease. The cells are dying, they will continue to die. But if we can trick the brain into thinking there's more living cells and we're getting more neurotransmission happening, then that's a good thing. Now, every good medication has side effects, and in this case, it's not even unexpected side effects, because that same acetylcholine that we're targeting in the brain is also available in the gut, in the bladder, and at the heart. So not surprisingly, if you're stimulating the brain, you're also stimulating the bowels. So you may get nausea, bloating, diarrhea. So 1 out of 8 cases that we treat with this group of medications will get these side effects. And sometimes it's bad enough that we actually have to stop the medication. So for instance, severe nausea or people vomiting, clearly we have to stop the medication. Similarly, going to the bathroom and to avoid more often. If it's only, instead of going to the bathroom 4 times a day, we're now going 5 times a day, that may be tolerable. But if you have to go to the bathroom every hour, it can affect your quality of life. You may not be able to go shopping and the like. So bowels, bladder, and then heart. About 1 case in 100, and by the way, that's 1 in 8 cases that affect bowel and bladder. So 1 in 100 will have a change, a slowing of the heart rhythm, and that can be very dangerous because it can cause dizziness and falls. And of course, falling, breaking a hip, and being admitted to a hospital is probably not one of the better things that can happen to people. So this is the most serious side effect. Fortunately, it's about 1 to 2 cases per 100. The last medication that is used as a quote-unquote treatment for dementia is memantine. What's remarkable about this medication, it was discovered in 1968 and was actually meant to treat diabetes. In the 80s, we discovered that it actually activates receptors in the brain. And that's where the idea came to use it for cognition. The reality is that there's not a lot of data that confirms the positive impact of memantine. And, there is evidence in the Petri dish, in the lab, that brain cells are less likely to deteriorate if they're living in a culture with memantine in it. The good news is there are few side effects, but the bad news is it's not covered by Ontario Drug Benefits simply because they don't have enough evidence that it's a benefit to patients. And so they're considering it more of an experimental use. And so client pays or insurance pays. So memantine is a bit of a wild card. Canadian guidelines do suggest that there's a trial of adding memantine to more advanced stages of dementia. I haven't had a lot of positive benefits. I would say that of the hundreds of times I've tried memantine, there's maybe a handful where I can say with confidence it made a difference. And so, but more importantly than just treating the primary disease, in chronic diseases, we said that treating the symptoms has an important role. So as the disease progresses and it affects orientation to time, it can affect our sleep and wake cycle. And many of you that are caregivers, of course, would know that. Sometimes a person gets up in the middle of the night and doesn't know that it's night and should be going back to sleep. So sleep is an important element for the person with dementia, but also for caregivers. So we can help with sleep, and trazodone is sort of our first trial medication, and mirtazapine is another one that we often add. If you realize your memory is going and you're not as independent as before, it's not surprising that there may be some depression or anxiety associated with that. Again, there are very good antidepressants, anti-anxiety medications that can be used to control symptoms. So citalopram and escitalopram, they're very similar medications. Venlafaxine, again, mirtazapine and trazodone can be used in this as well. And then there's agitation, paranoia, and then sometimes psychosis. So when trazodone doesn't work anymore, and there are real fears for their lives, and they're they won't come out of their room, and there's no quality of life, then an antipsychotic like risperidone or quetiapine may be appropriate, and they do work extremely well when used for the right thing and in the right dose. So my experience with the antipsychotics has been very good. I do wait. I try everything else first, and only when we're sort of desperate and we're not getting benefits elsewhere, then I'll turn to the antipsychotics. And normally now we would have a break, but because everyone can sneak away for their little bio break as I'm speaking and I'll never know, I'll just forge on ahead. And so we will talk about vascular dementia next. So there are different types of dementia associated with circulation. There's the stroke-related dementia, where, of course, in a stroke, there's a large vessel that's blocked, and the circulation to the large portion of the brain is cut off, and then that part of the brain dies. And so about 20% of people that have had a significant stroke in the years that follow will develop dementia. And of course, a person who's already had a stroke is at increased risk of having more. And the more strokes you'd have, as you can imagine, that will accumulate, and the impact on the brain will be to develop dementia. Now, there's also vascular dementia, which is sort of more subcortical, and it's sort of more insidious. It's much smaller vessels, and it really happens deeper in the brain. And so there's thickening of the walls in the arteries. They get stiff, they get twisted, the blood flow is reduced, and so it will create different symptoms by its location. So here in this picture, we're looking at the brain in a cut from top to bottom of the brain. So it's not sort of front to back like we normally do, but it's top to bottom. And so you have the temporal lobe here, you've got the parietal lobe here, right? And so here you have the blood vessels going through and feeding the brain, and then this little white box is the blow up here. And you see there's a wee tiny little block, and it's only one out of like a dozen major arteries in the area. But you can imagine if this one's blocked, this part of the brain is going to have a little bit less blood flow, a little bit less oxygen, a little bit less nutrition, and it will affect this part of the brain. So here it's not like a sudden stroke where you block this artery and all of this part of the brain dies. No, this is a little artery, one of the little branches, and now it's affecting a part of the brain downstream, but it's more diffuse. And so if you take a brain scan now, and of course this is like a slice through the brain, you can see sort of normal tissue here, but then you see these white little plaques, right, all over. And these are parts of the brain that have not had sufficient oxygen flow and that are starting to show cell death. So when we talk about microvascular disease showing up on a CT scan or an MRI scan, these are the images we're talking about. So we talked about Alzheimer's disease and how it sort of starts in one part of the brain and then spreads out to other parts of the brain, and it's gradual, and over time it affects functioning. Well, vascular dementia is a little different, because here, every time you get another little clot that gets clogged, stuck somewhere in the plumbing, you're going to have another change. And it may only, it may happen over a couple of days, but it will be a change. And then maybe for a couple of weeks, nothing really happens. And then there might be another little clot that appears, and then another little vessel that gets blocked, and another little change. So instead of being sort of a gradual decline like we have in Alzheimer's disease and vascular dementia, you're more likely to have stepwise progression. So stability, drop down, more stability, drop down, right, with each clot. And because, of course, the circulation is not, it's not like a rigid pipe you have in your house, but the circulation is flexible, it's collapsible, you can put pressure on it, you can change the color of your hand by blocking the arteries and leading to your hand, right? So these are flexible vessels. So you can imagine if your heart is pumping more weakly, some of these hoses, if you like, might have a kink in them and there might not be a lot of flow on the other end. But then on other times when the blood is flowing better and the heart is pumping stronger, maybe the hose is now unkinked and there's actually good blood flow. So you can imagine from day to day, even from hour to hour, you can have changes in the blood flow to different parts of the brain that can actually affect how you're functioning from hour to hour and day by day. And now, of course, because the whole brain is inside this box, which we call the skull, and is dependent on this circulation to feed it, depending on where the circulation is breaking down, that is the function that's going to be affected. So if the temporal lobe is affected, my language will be affected. If deeper parts of the brain are affected where different movements are integrated, where I need some cerebellum work, some motor area work, I need to adjust from the feedback I get from my body, so the sensory part of the brain is integrated. So when we get to fine motor skills like tying a bow tie, tying a bow on your shoe, getting a zipper to line up and getting it to close proper, these require a lot of the brain. And so the more there are little vascular damages along the way, the more likely complex things like language, like fine motor skills are going to be affected. And speed of processing is sort of the term we use for how quickly we come up with an answer. So if we're looking for a word, if we're trying to solve a problem, there's a certain amount of time that takes. And as you can imagine, when you're 29, you're pretty fast at being able to do some mathematics and solve a problem. And then maybe you're a little slower at 55 and you're even more slow at 75. Well, if you have a lot of vascular damage, it's even slower. And the way to think about it is, if the brain is made up of little circuits, electrical circuits, let's call it a network, almost like a road network, right? So if, when I drive to work, there's no accidents, there's no construction, there are no potholes, I can get to work in half an hour. If there's damage from the winter and there's potholes, if there's just a couple, it slows me a little bit, but if there's potholes the entire length of Prince of Wales, it's gonna be a slow commute in. And in the same way, if you think about it, if there are all these little white spots on the brain where there are brain cells that are dying, then communication from one side of the brain to the other side of the brain is going to be slowed. And so that speed of processing is an important element in vascular dementia. And memory could be slower as well, right? So remembering the name of someone may be slower. Now, one of the features of vascular dementia is because it's not all happening in the hippocampus, because it's not all happening in the temporal lobe, we're more aware of the changes. So we'll notice that things take longer. We'll be more frustrated. We're more likely to actually, when they come to my clinic, they're more likely to tell me that they have a memory problem. In contrast to the person with Alzheimer's disease, who, because they have poor memory, they don't remember that yesterday they forgot where their keys were and they spent 4 hours looking for them, or that they forgot to pay a bill and there was a big ruckus and there were phone calls and all kinds of desperate things. Of course, the next day they don't remember because that is their problem. That is their disease. Whereas here, our hippocampus might still be relatively intact. And so, yeah, so people with vascular dementia are more likely to be aware of their cognitive changes. And at least in part of that, they're more likely to have depression. So they may be more aware, and that may cause depression, but it may also be that the parts of the brain that have to do with emotion may be having these white spots as well, and hence it may be sort of a primary cause of depression. So as you can imagine, oh, this is interesting. We have a little T in our vascular dementia. Good. To manage vascular dementia, we need to be even more concerned about the vascular health. So blood pressure control, heart rate control, blood sugar control, cholesterol control, right? These are the things that can worsen our circulation and can worsen our cognitive impairment. Obviously, smoking, ideally we would stop smoking, because every cigarette is like adding another little clot to the plumbing. In vascular dementia, there is some evidence that cholinesterase inhibitors also can help. So the same medications, the three we mentioned earlier, right, can also be used in vascular, can be tried in vascular dementia. Obviously, if depression is more likely in this dementia, let's treat it with our antidepressants. Again, let's keep our body as healthy as we can with exercise, brain exercise, and social engagement, which of course right now we're not allowed to do as much, but we can socially engage through video chats like this anyways. So Alzheimer's is one of the most common, and circulation problems is certainly one of the second most common types of dementia. And so now we're going to plow on and sort of talk about the rest of them, or not all of them, but the most substantial ones, the ones that you're most likely to encounter. So we mentioned this one earlier, frontotemporal dementia. It is common, it is quite common, and it's typically diagnosed in a younger age. So if you remember, we had those little pie graphs there, and so it's typically a younger population than sort of our typical Alzheimer's group. We said up to 40% it can be familial, and then this is sort of one of the tau mutations that are associated with this, which is the same protein, but it's not the same mutation, and it's a different structural problem. So here now we have a brain. Obviously, this person is deceased, so this is after autopsy. But now you can see here, this looks like pretty normal brain in the back part of the brain in comparison to this, right? So here you see it's really shrunk pretty badly. And of course, this is the frontal part of the brain. But if you look here, the tip of the temporal lobe is also showing a bit of shrinkage. So it's certainly not as plump, as healthy as the posterior areas of the brain. So this would be, you know, advanced frontotemporal dementia, but just again to show you that it really is named by the location, the part of the brain that's affected. And that's, of course, how we diagnose it in early stages clinically. So again, you know, what did we say about the frontal lobe? It's executive functioning. It's all the complicated things our brain can do. And we said the temporal lobe is heavily involved in language, also orientation, and some memory. So there are two groups of frontotemporal dementia, and you won't be surprised that one of them is the frontal type. And in the frontal type, we have that loss of executive functioning. So we can't plan events anymore. Our judgment is impaired. And that can affect our behavior. So if our judgment is impaired, we may be disinhibited. So let's say that you know, I've gone to the casino in Hull maybe 3 times in my life. The times I went, it was fun, but it's not something that I, terribly interested in. But let's say I start developing frontotemporal dementia, and now my judgment is going to be impaired, and I may become disinhibited, and I may not think about, putting my money into a machine in the same way I do now. And so I may actually start developing a severe gambling problem or a severe alcohol drinking problem. Another type, that's the disinhibited type. There's also the apathetic type, which is that they simply stop doing everything. Here's a 55-year-old that is sort of in prime at work, and all of a sudden just says, I don't feel like going to work anymore. I think I'm just going to stay home, and no, I don't want to do this. The boss says, hey, can you do this for Friday? No, I don't think so. A change in personality, a real change in personality. Overeating is another one of those disinhibition kinds. And again, we said this is more likely to be familial. And then there's the temporal type, obviously, the frontal type and the temporal type. And in the temporal type, we have more of the language issues. So we're more likely to have the aphasias, which we'll talk about a little bit more, and semantic dementia as well. So in the temporal type, we have the progressive non-fluent aphasia, and I do have quite a few patients with this progressive word finding difficulties. Because they can't find the word, they get stuck. So they'll be in the middle of a sentence, and then they can't find the next word. So that the fluency is broken. Sometimes they have difficulty pronouncing words as well. And these people typically are quite aware of their difficulties. They'll say, I used to be really good at public speaking. Now, when there's 3 people in the room, I can barely tell a joke, right? And so they're usually quite aware of their challenges. And interestingly, in the same way that the speech becomes sort of discombobulated, some of these people also show some changes, some physical changes that are Parkinson-like, that they're not as coordinated, they're more frozen and more stiff in their movements, just like their speech is that way. Now, the semantic type, they have a different problem. It's not that they can't find the word, it's that they use the wrong word. So a typical example is a couple comes to see me, and the husband has this condition, and he'll tell me, he'll start talking about his daughter that's beside him, but it's his wife. So what's happening is that he's opened the right drawer, which is family relations, but he's pulled out the wrong word, the wrong name, but he's not aware of it. So they'll talk about their daughter instead of their wife. They'll talk about the parking lot rather than the garage. And you can imagine that if they're in a sentence, they're saying, and so I met my daughter in the parking lot, when he's saying what he wanted to say was that he met his wife in the garage. Of course, it's really hard to follow what they're saying. And with time, and what's difficult is that they're fluent, right? They don't recognize that they've pulled out the wrong words, and so they just keep talking. And eventually their sentences become more and more meaningless to us. To them, they're trying to express what they've expressed all their lives, but to us, because we're hearing the actual words they're using and not the words they intended to use. And unfortunately, these people are typically not aware of their deficits. So they'll look at us going, what are you waiting for? Answer my question. And we're just struggling to make sense of it all. So in the frontotemporal dementias, these typically do not respond to cholinesterase inhibitors. That doesn't mean that we won't give them a try. It's devastating to have a 58-year-old who has difficulty speaking and to say that, right, that there's really not much we can do. So we may do a trial of a cholinesterase inhibitor just to see if we can get some benefit. More importantly, though, if we have the frontal variant, if there's ways we can control some of these abnormal behaviors, of course, that'll help. Because if, you know, an example of a frontal behavior would be to continuously tap on the table. And so you're talking to them and they're tapping on the table. You go to the restaurant and they're tapping on the table, and it's just that they can't stop themselves because they don't recognize the tapping on the table as being something that's not appropriate in a restaurant. So you can imagine how the families then end up not going to the restaurant. So if there's a way we can control some of these behaviors, everyone's quality of life can benefit. And again, we want the circulation to that part, the frontal and temporal parts of the brain, to be as good as possible. So again, we're going to manage our blood pressure, glucose, cholesterol, and we're going to exercise the brain as much as we can, exercise our body and the like. So the management is similar in most of the dementias. Moving on to Lewy body dementia, you can see here that inside this neuron there is a completely unexpected circular vesicle. The guy who discovered this, of course, was Dr. Lewy, and that's why we have named this condition after them. And Lewy body dementia affects the posterior part of the brain a lot, but also the frontal part of the brain. So the posterior part of the brain, if you recall, is actually where vision happens. So imagine that those neurons at the back of the brain that are normally interpreting what the eye sees and the messages it gets from the eye, now those cells are getting sick and misfiring. So the eye doesn't see a person, but the brain, that posterior part of the brain that creates images from the signals from the eye normally, now is creating images all by itself. And that would be a visual hallucination. Sometimes they're more delusions, like let's say there's actually a curtain, it's blowing in the wind, and then the person might say, well, what's this lady doing here? Because it looks like a flowing dress, right? So, so these are either misinterpretations or completely things that are not there. So one gentleman who had the Lewy body dementia would tell me that when he looks out the window across the street, he sees the neighbor's house and there's children playing on the roof. And of course, that would be very dangerous and not something you would expect to see. And of course, it wasn't the case, but somehow his brain was superimposing images of children onto this roof. And so that is a kind of visual hallucination you can have with Lewy body. And because of some of the damage to deeper parts of the brain, you can develop symptoms that look very much like Parkinson's disease. So not necessarily the resting tremor, but certainly the rigidity, the stooped posture, the small steps are classic sort of in the evolution of Lewy body disease. REM sleep disorder. So normally when we dream, the body has this protection mechanism that it turns off all physical motor activity. So when we dream, we actually don't move our arms and legs, because if we did, we'd be hurting ourselves or others, and that wouldn't be a good thing. Well, unfortunately, in REM sleep disorder, that's exactly what happens. You're acting out your dreams. So you're not sort of paralyzed, which is the normal way to be. you're actually acting out our dreams. So people with Lewy body dementia, the spouses sometimes will say, look, I had to go move out of the bed because I would get hit. Sometimes he would wake up and tell me that he was fighting in the war, and he was, you know, so, and he was hitting me. So he was, you know, these are the kinds of things that this REM sleep disorder is a sort of a classic symptom of Lewy body disease. Visual spatial difficulties beyond hallucinations. Over time, you may develop the inability to pour a glass of water because you're missing that depth perception, and you may miss. And Lewy body disease, like vascular dementia, has that sort of characteristic of being fluctuating. So in the morning, things are okay. In the afternoon, whoa, now we start seeing children playing on the roof. And, you know, when we have difficulty concentrating and people are talking to us, but we're doing something completely different. So those are the sort of the key symptoms that make up the diagnosis of Lewy body dementia. So one of the challenges with Lewy body, and one of the reasons it's often underdiagnosed, is especially early on in the disease, is that you may have some memory problems, and so it may be misdiagnosed as sort of an atypical form of Alzheimer's type dementia. But often, because you're showing the rigidity and that stiffness, you may be diagnosed as having Parkinson's disease. In Lewy body dementia, there is some evidence that rivastigmine, which is one of the cholinesterase inhibitors, may be a little bit more effective than the others. And so typically I will treat my patients with Lewy body dementia with rivastigmine as the first trial. And one of the advantages of the rivastigmine is that there's a lot of flexibility in the dosing. So if you do start having a little bit of bowel difficulty, you can take a small step back and still have some benefit from that. The REM sleep disorder can be very disruptive. If you wake up from your dream and you call the police because there was someone who broke into your house and whatever, that transition from dream to wake and can be very traumatic. And so there are treatments specifically addressing the sleep issue, the sleep component. It is, as I said, one of the most disruptive in caring for someone with Lewy body, but it's also one of the most dangerous for the person themselves. So we try to control those symptoms. As the Lewy body progresses and the stiffness, the difficulty with movement gets worse, we can consider actual Parkinson's medication. So I have a lot of my Lewy body dementia patients that are sort of in more advanced stages that are on a small dose of Sinemet. And it seems to just soften out movements a little bit. It's not the same response as you would get from the true Parkinson's disease, but it can help with mobility, balance, walking, which, you know, at the more advanced stages can be really disruptive for care. Finally, you might have psychological changes, and a lot of people, a lot of physicians that aren't sort of familiar with the Lewy body hallucinations feel that they need to treat the hallucinations, but antipsychotics can cause actually worsening of some symptoms in Lewy body dementia. So we actually try to avoid them if at all possible. So I try to explain to the family, you know, why these hallucinations are happening, and to accept them, but to minimize their impact. To say, okay, you see those children, you know, I don't see them. Let's just, that's fine. Let's just go, and why don't we go for a walk and distract them, and then that way it decreases the sort of significance of the hallucinations and makes it less, gives it less importance, because Like I said, if we can explain it, usually families can accept that this is part of a disease and simply work around it. And again, we want to manage the vascular risk factors and do all those good brain health activities in Lewy body as well. So let's go right from Lewy body dementia to Parkinson's disease, because they are what I would call cousins. And Parkinson's disease specifically affects the substantia nigra region of the basal ganglia. Dopamine is actually what's missing. It's depleted in this disease, and that's why we give L-DOPA, which is the sort of the generic name for Sinemet. So the alpha-synuclein, which is actually the deposit that causes Parkinson's disease, can actually aggregate into Lewy body type shapes. And that's why we say they're sort of cousins. Parkinson's disease is limited to the substantia nigra. That's where the disease starts. That's the main focus of the illness. Lewy body, it's much more diffuse disease, but it seems to affect connections to the substantia nigra, and then that's why we get very similar symptoms. So you get the stiffness, the resting tremor, the rigidity, and sort of this is sort of the classic picture you get. Shuffling gait, that resting tremor of the hand, decreased arm swinging, slow speech, monotonous, blank, not a lot of facial expression, and then sort of that tilting forward posture. And so Parkinson's disease, as I said, starts in the substantia nigra, but of course, as any other disease, as it progresses, it does spread out. And eventually it can affect memory, attention, judgment, and planning. And in fact, after many, many years of Parkinson's disease, you can expect at least half, if not 3/4 of people with Parkinson's disease to develop some dementing process. And again, to show the two side by side, Lewy body dementia, we start with the hallucinations, the sleep issues, and then later get physical symptoms. Whereas in Parkinson's disease, it starts off with the physical symptoms, and then you get some of these reasoning judgment type symptoms. In Parkinson's disease, obviously, we treat Parkinson's disease first. Sometimes we'll consider a cholinesterase inhibitor. I have rarely used cholinesterase inhibitors in patients with Parkinson's disease. And of course, if they have other psychological symptoms, we can treat that. Again, with advanced Parkinson's disease, they do develop hallucinations. And so we might be tempted, again, to give an antipsychotic to reduce the chances of having hallucinations. In this case, it's a sort of a balance thing. The more we treat the movement disorder, the more likely we're going to get hallucinations. The more we treat the hallucinations, the worse the movements get. So we're kind of in a delicate balance all the time. And of course, we want to do the rest, the vascular and the good brain health. Then there's a group of dementias which we call the Parkinson's plus group. And they usually come in first with executive functioning difficulties. So the families will say, used to be real good at putting together an IKEA set of shelves. Now can't seem to sort of get it together. And sort of the planning, the execution is sort of going, oh, wait a minute, that was the wrong way around, turn it around and fix it, that kind of thing. It does often affect language. So if you have executive functioning and language early on, and then have Parkinsonism, you're probably talking Parkinson's plus. They sometimes will have visual spatial elements as well, and sometimes will have depression as And again, in the Parkinson's Plus, we will consider Parkinson's medications to see if we can help with the movements. Obviously, if they're depressed, we'll consider an antidepressant. And we manage the other components as always. So we've talked about some of the sort of single cause dementia types. But remember that when we looked at our pie graph earlier on, a third of dementias are probably mixed. And it sort of makes sense. The older you get, the more likely you are to have multiple different types of failure, right? So you may be starting to show signs of early Alzheimer's changes in the hippocampus, but then you've also got 85 years worth of vascular damage accumulating, and maybe you're starting to have a couple of hallucinations, so you might have some Lewy body changes as well. So multiple dementias, certainly causes for dementia, can coexist. They will likely have a greater impact on the brain than any one type by itself. As I said, if you have a little bit of Alzheimer's changes, no, you might not notice. No one may notice. But if you add vascular problems, and now you're affecting the circulation to the brain, now you've multiplied that by 2. And it may have a greater impact than the vascular change would by itself if there wasn't Alzheimer's changes, and the Alzheimer's would have by themselves if there wasn't a vascular problem. The challenge with diagnosing mixed dementia is because it's so difficult. There are no rules. There is no pattern. You can't say, well, mixed dementia starts like this and ends there. Well, it depends what you're mixing with what. It's sort of like a soup, right? Depending on what you put in, it's going to taste very different. So depending on what the causes are, it'll look very different. So it's often hard to diagnose because we have elements that look very much like Lewy body or very much like an aphasia, but there are more memory problems than we would expect, and they have difficulty putting shelves together. Well, now there's no right pattern, so maybe we have a mixed dementia in this case. All right, so we've pretty much talked about all the different types of dementia that there are. I mean, there are other types. We can talk about those if need be in the question and answer period, but let's talk about delirium. So delirium is a sudden change in ability to think. And typically it affects level of consciousness. So if you remember earlier on when we defined dementia, we said that you have to have a normal level of consciousness. Well, that's because delirium is the sort of other cousin of dementia, which is the acute change cousin of dementia. So what can cause delirium? Well, medication can cause delirium. If we give you enough drugs that affect the brain in different ways, you won't be able to think clearly, you won't be able to speak clearly, so that can be medication-induced. Infection is a frequent cause of delirium. Dehydration, brain trauma, alcohol, right? Surgery, anesthetics, any of these can cause delirium. Now, what's annoying is that often, if you have a little bit of underlying dementia, so you have some early Alzheimer's changes, then you get an infection, and all of a sudden it'll get 10 times worse. So it's really important to be able to recognize when there is delirium. It's one thing to gradually change over time. The dementia is gradually progressing. It's a whole other thing if from one week to the next there's a huge change. So that's the importance of being able to diagnose the delirium, the acute change, which may be reversible, right? An infection may be treatable. And if the infection goes away, then maybe the delirium will go away and we'll be at a premorbid state. So the tricky part is if you have dementia, you're more likely to get delirium. And the last D, because we have the 3 Ds, and when we're talking about this, dementia, delirium, and depression. Of course, depression can look like dementia, but it comes on pretty quickly. So someone who won't get out of bed in the morning, won't make a meal, won't shower, it could look like dementia, end stages of dementia, but if it's sort of recent onset, like in the last couple of weeks, and there was sort of mood component to it, there's less energy, there's loss of interest, then you may be in a depression state. And of course, a depression is treatable often, and so the function can return. So depression could be a cause of mild cognitive impairment, right? They present like dementia or on the way to dementia, but then it's a reversible condition. So, and I mentioned this a little earlier, there is this sort of unique interaction between depression and dementia. So that early on in dementia, when you may still be aware of the changes that you're having, you're at an increased risk of depression, because you're saying, like, I don't know what's going on with me. I go to the store, I'm supposed to buy 3 things, and I can't remember one of them. So that could be reasonably causing you to be depressed. However, depression may also be simply part of the expression of the destruction of different parts of the brain. So if the mood center is affected, be it from a vascular event, be it from Alzheimer's changes or Lewy body changes or frontotemporal changes, right? It can be part of the symptoms of dementia. So sometimes depression precedes our diagnosis of dementia, because the person gets depressed, you treat the depression, but then despite that, they seem happier, but despite that, they can't seem to be able to put together that complicated meal that they used to be so good at, right? And then we say, so this was depression. That was just sort of one of the symptoms in the spectrum of early dementia. Right, and so we haven't really talked about cognitive reserve, but if you recall earlier on, I'd said that there seemed to be the impression that education could be a factor that decreases your risk of dementia, developing dementia. Or another way to put it is that the more you develop your brain, the more accumulated damage you'll need to show an impact in function. So that idea of cognitive reserve is that the more we educate, the more we train our brain, the more we educate, we do different things, the more complex the connections are in the brain, and the more chance there is that the brain can sort of relearn something through another pathway if there is a little bit of damage here or there. So in the same way, depression, maybe what it does, it decreases our cognitive abilities because it impacts this cognitive reserve. We don't have that same cognitive capacity. So it may be unmasking a dementia that's going to be developing later on. And again, this table is a bit busy, and I apologize for that, but it just compares dementia, delirium, and depression. Onset, we said dementia is slow and gradual, maybe stepwise, but still slow and gradual, whereas delirium, it's acute. Within hours or days, the person is completely changed. Depression is more gradual as well. The duration for dementia, it's years, I would say decades. Now we believe that the changes associated with Alzheimer's disease can start as early as 40 years of age. So years and decades is for dementia, hours and days to develop delirium, weeks to months for depression. The course is progressive, except the stepwise for the vascular. Delirium, it fluctuates a lot more, there's more sundowning, and depression, interestingly, seems to be worse in the morning. Alertness is normal in depression and dementia, but is that fluctuating thing in delirium that helps us to know that it's delirium. Whoops, sorry about that. And orientation initially is sort of normal in dementia. It's always impaired in delirium. People in a delirium have no idea where they are or what time of day it is or what day of the week it is. Orientation, if you push someone with dementia, with depression, they do know the date, they know where they are, it's just they don't want to tell you, they don't want to do anything. So memory is impacted in dementia, it's impaired in delirium, and it may be slightly impaired in depression, but it's not a permanent change. Delusions can come in later stages, bizarre ideas, disjointed thinking is delirium, and in depression, it's more that you have this negative thoughts, and so on. I won't read the rest of the table. What we have tried to cover today is dementia from a point of view of a stage of severity of disease of the brain. So you have normal aging, mild cognitive impairment, and dementia. So it is that most severe stage. We've talked about things that can happen to the brain cells themselves: Alzheimer's disease, Lewy body disease, frontotemporal dementia, Parkinson's disease, that kind of thing. We've also talked about the outside, the body, the circulation, infection, chemicals that can affect the brain and move you from normal aging to mild cognitive impairment to dementia. We've tried to talk a little bit about our sort of therapeutic approach in the different dementias, so the cholinesterase inhibitors, the memantine, and lastly, we've tried to sort of distinguish dementia from depression and delirium. And so at this point, I'm going to stop, and I am going to open it up for questions.